Good day, and thanks for tuning in. I am Sarah Louden from Total Health Conferencing, and this is one of our talks on health matters. Today, we're going to be talking about colonoscopies. Why are we doing this? There was a recent article that's kind of headline was colonoscopies may not matter. We may not get any more information from not having them than we do from having them. So we decided as a group of informed, unbiased people that we get together and we give you the information we know that makes you a healthier, happier person. So I want to start by saying colorectal cancer ranks third among cancer deaths in both men and women in the United States, with about 100,000 new cases annually. The good news is over the last probably 8 years, colorectal cancer rates have been declining about 2% a year. And a lot of this can be attributed to the increase or uptake in colorectal cancer screening. Again, I mentioned that there was a recent New England Journal article that came out that Dr. Parikh is going to talk a little bit more about a little bit later that gave us this headline that maybe colonoscopies aren't as useful as we think. We want to set the record straight, so we're going to talk this through. I'm joined by three incredible people. I know them all personally. I know their work personally, and they're people that are heavily invested not only in this space from just an information perspective, but they're people who deal with colorectal cancer every single day. We have Dr. Manju George, colorectal cancer advocate and scientific director of Paltown. We have Dr. Aparna Parikh, GI medical oncologist from Mass General Hospital. And we have Mike Sapienza, CEO of Colorectal Cancer Alliance. Mike, I'm going to start with you first, as I know you may have to leave us a little bit early to go doing your wonderful work in colorectal cancer advocacy. So I'm going to start with you and ask the basic fundamental question. Who are you? Who's Colorectal Cancer Alliance? And what is your mission, sir?
Sure. Thank you, Sarah. And I appreciate you having me today. Michael Sapienza. I'm the CEO of the Colorectal Cancer Alliance. Just a short personal story. Unfortunately, my mom died of the disease at the age of 59 on Mother's Day in 2009, which kind of catapulted our family and friends to start a smaller organization, the Christopher Life Colon Cancer Foundation, in which we then merged with the Colon Cancer Alliance in 2016. We are now the world's largest colorectal cancer advocacy organization, and we focus on three things. So screening, we just launched what we call our campaign, the Lead From Behind campaign, with Ryan Reynolds and Rob McElhenney, which we're super excited, just saw recently a 36% increase in the number of colonoscopies actually being booked in the month post Lead From Behind. We have a really robust care program in which, we help patients. The way we say it is we don't want them to feel like they are alone, and we want them to live longer. So a lot of medical advocacy around biomarkers, clinical trials, et cetera. And then we just finished our peer-reviewed research RFP, and we will be awarding about $850,000 worth of research before the end of the year. So that's me in a nutshell.
Wonderful, wonderful. Mike, when you first kind of heard of this article and then read it yourself, what were your thoughts? How do you feel this kind of impacted what Colorectal Cancer Alliance and others have been working so hard to do?
Yeah, I mean, first, I would just say my mom died of colon cancer. She did not have a colonoscopy. If she had a colonoscopy, she would be alive, period. And yeah, I mean, first of all, the news headlines were incredibly misleading. We did contact CNN. We got them to eventually change the headline, thank God, because there's not a doubt in my mind that some of those headlines will cost people their lives, period. That plain and simple, it will cost people their lives. And so what effect did it have? I think it had a major effect on, people already are fearful potentially of being put under sedation or doing the prep or actually taking time off of work. And I don't think it did it as any service. Yes, the study said that there was an 18%, reduction in CRC deaths. But the clear important piece is of those that actually, came and showed up and got the colonoscopy, but only 50% of the people that were offered a colonoscopy actually showed up. The real stats are, and I got to look, I just always forget, 31% reduction in mortality incidence, and 50% reduction in mortality. I'm sorry, but again, if it were me, my mom, my dad, any of us, I would say get that colonoscopy because it will save your life, period.
Yes. I really just want to hang there because so many times as lay people, people that are not affected by cancer, maybe people that don't have risk, what we think of as risk. Oh, I don't have a dad who died. I don't have a mom who died. They think that they're at a lower risk. So it's kind of like you listen to the headline on your way out to work or in the car, and it makes you think like, oh, I could put this off. Oh, I don't need this unless something's happening and I feel it or whatever. So I think it's so important that there are organizations like Colorectal Cancer Alliance that don't just say, oh, we know that headline is not correct, but you then, aggressively pursue these news organizations to have them update or reverse the things they say. What other types of things do you do to reach the people, the audiences that need to know information like this and other information that's life-saving? What kind of forms of information or advocacy does CCA do in those arenas?
Yeah, Sarah, that's a great question. It was like an echo chamber amongst GIs, and I'm sure the other members on this call will talk more about that. And what I would say our job is how do we get the correct information to the general public? Yes, GI should be up in arms over the way that the media did that. But what's most important is what do people that need to get screened actually think about a colonoscopy or others? And certainly there are barriers to colonoscopy. We know that, right? We absolutely know that. But again, it will save your life. So some of the things that we did, we actually just launched another new campaign that's focused on African Americans called They Didn't Say with Charlemagne the God. And that is really all about going to our quiz. So it's quiz.getscreened.org to get a recommendation on which screening is right for you. And it actually, you can talk to one of our live navigators, et cetera. But it's really, Charlemagne the God is an influencer in the African American community and really helps, obviously, if I get on and I'm trying to talk to the African American community, most people probably won't listen to me. So, we really focus on those types of communities that reach people that are in need and that need to get screened.
And Mike, on that note, talk to me about disparities a little bit. We get these bursts of attention. So we saw when Chadwick Boseman died, it was like, he's young, he looked healthy, he was like all of these things, he's Black, he's this really banner carrier for this community. And so you get to almost ride that wave a little bit to outreach and educate through advocacy. But talk to me a little bit about the importance of making sure that we're reaching diverse populations with equally powerful messaging that targets their communities.
Yeah, and I lump it into three categories. There are more, but African Americans, 20% higher incidence rate, 35% higher mortality. It's disgusting. So even though you may look at actual screening rates, and they're very similar, you look at Caucasians and African Americans, but unfortunately, there are other things, systemic racism, other barriers that are causing that higher incidence and that higher mortality. You also think of people that live in rural America. Are they going to drive 100 miles, take a day off of work, et cetera, to drive to an endoscopy suite that may be further away from them? Potentially no, right? So you see low screening rates there. And then people from the ages of 45 to 55 have a really low screening rate. They're busy moms, dads, have kids in college, et cetera. And that hits me personally because my mom was diagnosed at 56. She never got that screening. So, I think it's incredibly important that, and I'm just naming three target audiences, obviously, African Americans, rural Americans, and people 45 to 55. But there certainly are others, and it's incredibly important to reach those individuals.
Well, I am always impressed by the work that the Alliance does. It's so sad sometimes of how we get where we need to be, but then looking to see how people like you take crisis and tragedy and turn it into passion and promotion for things that save other people's lives so that others aren't in the situation like you, where you say, my mom would have been here if she had a colonoscopy. It's like, imagine the impact of that on so many people. So we want to say thank you so much to you. We know you've got a lot of good work, big work going on, and we got to dismiss that work. But thank you, Mike, for being here, and we will hold your banner as long and as high as we can to make sure that people all around the world know the power of advocacy and the power of an informed patient. So thank you so much for being here.
Thank you very much for having me, Sarah.
Wonderful. Okay, we're going to switch gears a little bit here and talk with Dr. Aparna Parikh from Mass General Hospital, because a lot of you may be saying, okay, that was a fast intro. We know a little bit about why we're here, but we want to dive a little bit deeper into this study. You know, we want to be able to tell you so that you can defend when other people say, oh yeah, I heard on whatever news, broadcast, colonoscopies aren't useful. We want you to be able to know why we're saying what we're saying by looking a little bit deeper into the study. So Dr. Parikh, I'm going to ask you, what is this New England Journal of Medicine study and what did it ultimately say?
Great. Thank you so much, Sarah, for having me. It's always such a pleasure to see you and Manju. And I wish Michael was still here so I could thank him for his kind of powerful words and kind of highlighting the take-home message that we're all trying to get out together, is that screening matters, and this study should absolutely not change the way we think about this. But let's break down the study a little bit, and there's some nuances that I think will even make the numbers that Mike pointed out to, that 31% and 50%, actually more stark if we actually kind of dive into the details and still further data that we need. So this was a large study. So it was, 84,000 some patients, and it was primarily, actually not primarily, it was entirely done in Europe. And so it's also to kind of basically appreciate and understand that screening patterns in Europe are also different than in the United States. Also, the study actually started in 2009 and completed basically through, I believe it was 2014. I can't remember if it was 2014 or 2015. But it started in 2009. And we even know that from 2009 onwards, and then if you look at the 2014 and beyond data, so from 2009, there has been a lot of improvement actually in screening and colonoscopy detection rates. So we know that the technologies used for preps and the operator dependency, operator expertise, the types of equipment used have also improved since then. And then when you look at the tail end of that time frame, so 2014 and beyond, we know that longer follow-up is needed as well. So in general, it takes around 8 years from a detection of an adenoma to for cancer to develop. Of course, that's not for everyone, but that's why the current screening guidelines for colonoscopies, if you have a clean colonoscopy, is 10 years, because most colon cancers, certainly not all, develop over a long period of time. And so the key point again was invitation. So the participants were invited to get a colonoscopy versus usual care. And usual care was basically no invitation or no screening at all. And as Mike pointed out, in terms of the people that were invited, only 42%, so 42%, so less than half of patients who got invited to take a colonoscopy, 42% actually underwent a colonoscopy. So that's really, really, really important. So when you're looking at a screening study, if less than half of your participants didn't even get the procedure that they needed to, diagnose their colon cancer, I think that number in and of itself should really drill home and nail home the point that, the far majority of patients in this study actually never got their diagnostic procedure of choice. And then, as Mike alluded to, if you look at the people who actually got the intervention, we saw much more impressive data in terms of what we would expect to see. Still a little bit less than what we would like to see. Some of the older data around colon cancer screening has shown that around 67% reduction in mortality. And in this study, again, it was 31% decreased risk of developing a colon cancer, and then 50% decrease of colon cancer deaths. So still 50% decrease in colon cancer deaths is still like incredible. It's not 67%, But again, if you go back to some of the points that I was just mentioning, the ability to diagnose better, so better preps, better equipment, better experience from the people that are doing colonoscopies, where in some of the countries in Europe that were part of this study, again, there's a learning curve into actually detecting the adenomas and then the follow-up. So if we take all of these pieces together, that 31% and 50% will probably be higher. And you take that 2014 and follow those patients, again, perhaps another, with added follow-up, perhaps another point insofar as really trying to move the needle of improving that those numbers to be better than we saw with the study, even in the ones that underwent screening. So I think what, my take home still was this, an invitation study. I'm still a little bit perplexed into how this made its way into the New England Journal. And would love to hear some of the editors that reviewed this paper and ultimately decided to publish a paper, why they felt that this was so compelling, because to Michael's point, the headlines were so disturbing. And I think what we know today still stands. Preventive cancer screenings, colonoscopies are still the best and trusted way to save lives. I think the other important piece is that there are other screening methods for people that don't have any risk factors. And those are stool-based tests, and there's DNA-based test, and there's, just guaiac fit testing as well, different types of things that each of those tests look for, and different intervals for those. But those are shorter interval tests. So fit testing is every year. The stool-based DNA testing is every 3 years. And so I think the other important piece, which is talking about screening, is that colonoscopy is still the gold standard, because not only can you, see those polyps that are pre-malignant too and treat them, but then also diagnose at the same time. Whereas stool-based testing is still better than no testing, but if it's a positive test or if you're having any symptoms, it's not an appropriate testing tool. But if you have one of those tests that are positive, you still have to undergo the ultimate diagnostic procedure, which is the colonoscopy. So I think lots of things to talk about from this study. I think the final point, going back to the timelines, there's some data suggesting that the detection rate for polyps, as I mentioned, kind of from earlier on to later on, is about more than half, I think, in terms, not quite half, but quite a bit higher than it was 10 to 15 years ago. So I think we would have expected, again, even more profound numbers than we saw with that 50% and 31%.
Well, thank you so much for breaking down the study and pointing out some of those nuances that maybe make it a much weaker argument that promoted the headline that said, colonoscopies may not be helpful. One thing that you said that I really think is like something that we've got to get this message through, and I want to make sure that I'm saying it right, and I want to make sure I'm right as I say it to you, Doc. When we think of a mammogram, we're looking for catching cancer earlier. When we think of lung cancer testing, imaging, some different modalities, we are trying to find cancer earlier. When we're doing a colonoscopy, we're doing it to prevent cancer from happening, to treat or extract the things that could become cancer. So it's not just about finding cancer earlier, like those other things that those are gold standards. We know as women, our mammograms, our pap smears, et cetera, men, PSA, standard of care for prostate cancer. Am I correct in saying that's another nuance that the general population may not embrace fully, that what we're saying with a colonoscopy is we have the ability to prevent, that goes back to that 2% reduction year over year for the last eight or 9 years, prevent a cancer from happening, which is what Mike was saying. If his mom had a colonoscopy, chances are she would be here. Am I correct in saying that? Is there anything else you'd like to add to that patient community?
Entirely correct. I think that is such an important point, that this is not just about finding the cancer. This is trying to prevent the cancer from ever coming to be, which we have the tools to do.
Yeah.
The other thing, Sarah, I just wanted to, I was just quickly here looking at my notes again, just when I was talking of that 50% or less in terms of the adenoma detection rate. So looking at it, it was 30% of the endoscopists who were included in the trial did not meet the adenoma detection rate. And so, again, this was different based on the different countries that were included. Some countries are doing better than others within this European cohort, but 30% of this people that were even doing the procedures were missing the detection rate that we consider acceptable. So again, highlighting that fact that even 50%, why it wasn't 67% or higher in terms of reduction in mortality. There's lots of things here.
Yes, appreciate that. Well, again, for the audience, listening to Mike, colonoscopies matter. Colonoscopies are still our gold standard. Organizations like Colorectal Cancer Alliance, the largest global advocate for colorectal cancer, they believe this. They want you to know it. They want you to take action. Then moving on to Dr. Parikh, telling us about this study. When we think about clinical trials, the design of a clinical trial is just as important as the results of the clinical trial. If there's flaws or limitations in the design, the information you get at the end doesn't hold water in certain areas. And so listening to her break that down for us, and I encourage you, listen to this and listen to it again. Have those takeaways when someone says, oh, I have a husband. He turned 46 this year, 47 this year. Doc said, you got to get a colonoscopy. Not me, I'm not getting a colonoscopy. For a lot of people, it's like right away, if I don't have these risks, if I don't have these symptoms, I'm not getting a colonoscopy. But listen to what Dr. Parikh is saying. This is about much more than finding cancers early. This is about the ability to prevent cancer so that you're here for years and years and years later with your family, with your work, with all the things that you have. It's so important that you understand in this era, and we'll get into this when we talk with Dr. George, this era of misinformation. You want to be able to have the information you need to say to someone who says, no, and didn't you read that it doesn't matter anyway? Well, no, I listened to this, social media chat that told me all the reasons why it mattered. So Dr. Parikh, thanks. Don't go anywhere. I know you're on call. If you do have to drop off, we understand, but don't go anywhere. We have some audience questions specifically for a GI med oncologist at the end. Manju, thank you so much for joining us. I'd like first for you to tell us a little bit about who you are and what is both Paltown University and CRC Trials Chat.
Hi, Sarah. I'm really glad to be part of this conversation. I'm a stage 3B rectal cancer survivor. I'm also a patient advocate. I used to be a biomedical researcher, so I bring that also into this. I want to tell you about Paltown University. This is a new project that Paltown has initiated. So Paltown is a nonprofit that supports Paltown. As you know, Paltown is a online international community of support and education for colorectal cancer patients and caregivers. It's now about 8,000 people or 8,000 members strong. And the reason we started Paltown University was because Paltown is on Facebook, and it has all the shared wisdom of all these people sharing their experiences, but it's not the best platform when you want to find information. Somebody posted something and there was this link to this paper, and you go back a week later and you try to find it, there's no way you can find it. So the genesis of Paltown University was really to create a place to put information so that people can come back and use it as a resource. So we did this during COVID, when COVID started and we had time on our hands, and we were like, let's compile all this information. So Paltown University basically is a great resource for newly diagnosed patients and caregivers. And it's sort of a distillation of the information journeys from patients in Paltown. So, we're looking at all these patient experiences, and we get these kind of questions, over and over again, the kind of things that patients want to know about. And we have taken that and then put it together in Paltown University. For example, there is the CRC 101 Learning Center. And where you can go in, a newly diagnosed patient can go in there and kind of find out, you have not heard about colon cancer, you have no idea what to do. You can go in there and kind of, within a few minutes, maybe 10 minutes, you can go read like the basic things that you need to know. What is your treatment going to be like? What are the members of your care team, and what kind of things are you going to get? And what are all the things that you need to know about biomarker testing? What kind of treatments you will get? What are the common side effects? What surgeries will you have? So it's a great place. And the best part is that it's not a place where somebody's talking down to you. It's the level of information that patients like to know. And then the other beautiful part about it is that it can be as simple as you want it to be, but you can also go up in complexity. So there is another section which is called the lecture hall, where we put in doc talks, which is basically conversation with experts in the field of colorectal cancer. So if you want to learn more, you want to learn about clinical trials, you want to learn about targeted therapies, you want to learn about anything that is a little bit more in depth, you can go there and listen to these lectures. And then there are other learning centers where we talk about diagnostic and surveillance testing, and there's precision medicine. So it's like, what we're thinking of is like, if you're a newly diagnosed patient, from the basics to as deep as you want to delve into it, you have all the information available. The CRC trial chat is a little different. It's a tweet chat on Twitter, and this is something that I started, and Dr. Parikh is also part of it. She's a moderator of the tweet chat. So this was something that I did on my own, and I was, there are tweet chats. There is the lung cancer tweet chat and the breast cancer tweet chat. So they're all on Twitter, and as I was on Twitter, I was seeing all this, like all the people getting involved and all this conversation. And I was like, oh, we need something for CRC. And I created this based on that. And so we have Dr. Parikh, and we have another GI medical oncologist, Dr. John Laurie. They are the two medical oncologists. And then we have two radiation oncologists, Dr. Christian Jethwa and Dr. Nina New-Sanford. And then what we do is we look at different topics, and then we invite subject matter experts. So for example, this month and next month, we're doing one on ctDNA. So we have Dr. Jean T, who's a pioneer in the field of ctDNA, and she has published so much. So she's the session expert. And then we have people who lead trials come in and talk about their trials. So the idea is basically to get patients and caregivers and clinicians and scientists all together to discuss about, important and relevant trials in colorectal cancer. And just my dream is to be able to make everyone talk together and to design better trials. Okay.
Well, I think it's wonderful. Manju, one of the things that's so inspiring about you that I've known from the first time that I met you is you are an empowered and educated patient who empowers and educates other patients. And why that's so important is because you have firsthand experience of how education has changed the course of your understanding of a disease that you live with. When we go to our doctors, when we go to our care teams, when we go to other, social groups, support groups, everyone is experiencing their life with or without disease. No one is experiencing our disease with our circumstances, with our fears, with our insecurities, with our questions. And what I've loved about how you have incrementally started to build platforms where it doesn't need you anymore. You are creating platforms where others can speak to each other, reach each other, depend on each other. And I absolutely love this CRC trials chat and the doc talks because they bring the information to the person who's having the experience, and they store information in a way that I don't know all the questions to ask when I'm newly diagnosed. Frankly, I don't know all the questions to ask when I'm 5 years in, or I get a metastasis, or a new diagnostic comes up like ctDNA. Well, what does it mean to me? So the way you've developed this for it to be a resource every step of the way, it's incredible, Manju. I know I speak on behalf of the patient community when I say what you've brought to CRC education and empowerment is really unsurpassed. And I have to say thank you, because just like Mike was powered by crisis, by tragedy, by something very personal, so have you been, and you've turned it into passion and potential. And it's just such a beautiful thing to see. So I have to say on behalf of the patient community, and I'm sure on behalf of Aparna and all the physician community, we are so, we sit in gratitude to know what your voice is promoting. Having said that, there's so much information out there, so much information. That's why we're here doing this. And we're adding to that information mountain. Manju, what do you say to people who speak out of a place of misinformation? How do you help correct that and point them to the resources that give them unbiased, reliable, credible information to manage their disease?
Yeah, this is something we're all struggling with, right? So I'll tell you this from my personal experience. So when, especially with relevance to the topic that we're talking about, which is colonoscopies, right? So when back in I think it was 2014 or something like that, I had a slightly low hemoglobin level, and one of my doctors suggested that I get a colonoscopy. Okay, so at that time, I'm physically active. I'm very careful about my diet. There is no history of cancer in my family. And I mean, I'm thinking, why should I get a colonoscopy? And what I did was I Googled it and I was like, what is this? And then it is so funny looking back, my Facebook feed had this article which told me you should not do a colonoscopy. It is not of much value to you. And it's it's for an average risk person, it probably don't have to do it. It's, and I'm reading this and I'm like, oh, okay. And then personally, I knew somebody at work who got a colonoscopy and he had an intestinal perforation. And I'm like, oh, I'm not getting one of these, So when my doctor mentioned this, I was telling her, do I have risk factors? Should I have it? I'm not really convinced that I should have a colonoscopy. And at that time, I'm completely outside the colon cancer world and I don't know the incidence rates. In my mind, it's a disease of, old white Caucasian people who eat meat and potatoes, who have no exercise, and I'm like, I'm not at all that person. So why should I worry? And I mean, the interesting fact is then my next hemoglobin was normal and we didn't really pursue it. And then 2 or 3 years later, I have my first symptom of blood and stool. And, the first thing I thought was that, I had this conversation about colonoscopy before, right? Maybe I should do something about it. And then I had talked to my primary care doctor. And in the end, I got a colonoscopy and that's what diagnosed me. Yeah. So, and what was striking to me was that, how I had this bias about maybe I shouldn't get a colonoscopy, and I go to Google, and how my Facebook feed showed something that, it was almost confirming my doubts that I had about colonoscopy. And then after I had the procedure, I was like, it's not the worst. It's when compared to all the things that I've had in my life, it's nothing compared to that. And it's funny that when you go back and read all the social media, or, you just Google something and read it, you can find information that agrees with what thoughts you have.
Yeah.
And, it's just, based on what you search, you will find things that tell you exactly what you want to hear. Yeah. And so the answer to your question is that anytime you hear anything in popular press about anything, the next breakthrough in cancer, what is probably the most important thing that you have to do is go find the source. What paper are they talking about? If possible, go back to that paper and try to read. You can read abstracts on PubMed, or you can on Google Scholar, you might be able to read it and see if what is said in that abstract is what is mentioned in the article. For example, this colonoscopy article, the CNN headlines was so misleading, the initial ones, and then they changed it, But actually, the interesting part is that if you go past the headlines and you read the article, it's not as misleading. It's the title that's misleading. And the problem is that it's the clickbait titles that make us stop and pause and read something, right? And so if you're the kind of person who's busy and who's just scanning through the headlines, that's probably not the message that you want to get, because that's probably not the right message, right? So if possible, read the article. And if you have more time, go to the source. Here, I'm really glad that we're talking about this, because from what Dr. Parikh said, the data, right? You go find the paper and you read it, and then you might have more information about it, and you can then make your own assessment about how accurate the headlines were, right?
Yes. No, I think those are all great points. And I really encourage people that are out there, even pre-cancer, go to advocacy organizations for the cancers that you're being screened for, or the cancers that you have high risk in. Advocacy organizations have the ability to cut through all the complicated stuff and give you at a patient level exactly what you need to know in a place of credibility. They have people like Dr. Parikh on their boards. So you don't have to have a GI medical oncologist in your life to be able to hear what a GI medical oncologist might say about something like colonoscopies, but really about anything, like Manju's saying. We search our bias. Do I really need a colonoscopy? The answer is no. If you don't want it, do colonoscopies save lives? The answer is yes, if you find that information. So it's so true. It's the quality of the search that gives you the answer that you are coming to. Ladies, I could talk to you for another 100 years, but we are at the end of our Health Matters chat. I do have 2 questions. One of them I really love because it dovetails on what Manju said, but Dr. Parikh, I'm going to start with you. This is a 2-part question. Is a stool test like Cologuard the same as a colonoscopy? And the second part of that question is, I'm scared of anesthesia, so how important would it be that I get a colonoscopy?
Both really good questions. So let's start with the anesthesia question. So some people think that colonoscopies require actually general anesthesia. It's not general anesthesia, actually. So it's some local sedation. And the other piece, and I've had colleagues and people I know that have actually decided to not take any sedation just because they wanted to be able to drive back, not disrupt their day. I'm not advocating for you to go, without any sort of sedation. It's certainly not a comfortable procedure. Just full transparency, I have ulcerative colitis, so I get my colonoscopies too, and I'm very vigilant about it. So I can speak to understanding that these aren't comfortable tests, but entirely manageable, and you don't have to undergo general anesthesia. Most of them, unless you're high risk with, lots of cardiovascular issues or breathing issues, that they do want an anesthesiologist on hand. Many of these are done in outpatient type of settings with the endoscopist and their team typically being the ones that just deliver.
Oh, we lost her. Maybe she froze.
Yeah.
While we wait for her to get back on, Manju, I'm going to switch questions and then we'll go back to her when she gets on. This dovetails with what you were saying. This question says, no one in my family has ever had cancer. Should I get screened?
Yes, the answer is yes. In my family also it was the same, right? So I think the risk for getting colon cancer depends on whether you have a colon and rectum, and that's the only risk. So if you have a functioning or not functioning, if you have a colon and rectum, then the chances of you getting colon cancer, there is a certain risk. So I would suggest that if you're past the screening age, that is past the age of 45, I would certainly recommend that you get screened. Yeah.
Perfect. Thank you so much. I'm going to just finish the chat by Manju just asking you to finish Dr. Parikh's question, which is Cologuard or stool-based tests like Cologuard versus a colonoscopy. Is it based on risk factors? Is it based on comfort level? Or is it something that if you're going to do something to screen, do something to screen?
Yes. I'll tell you this again from personal experience. My husband is, past the age of screening, and he's like deathly terrified of a colonoscopy, believe it or not. I'm sure that we have in our community a lot of family members who, I've got 5 colonoscopies so far, but, it depends. It's not, the idea of somebody probing a cavity in your body is so terrifying, even though, you don't really know any of it because you're under sedation, right? So you actually don't know that anything is happening to you because you're asleep. But the thought of it is so it's kind of terrifying to many people.
Yeah.
So I would say that, there is a saying that the best test is the one that can get done, right?
Yeah.
So if you're at risk, or if you're past the screening age and you are terrified of a colonoscopy, yes, a stool-based test is a good alternative. The issue is that, like, if those tests are positive, the next step would be for you to get a colonoscopy. So in reality, you're not really avoiding it. You are using a different way of screening. And I would say that if you are scared of getting a colonoscopy, that's fine. Just get some test, any test that is good for, screening CRC. And then maybe, if it's positive, then it might make you less scared of getting a colonoscopy, and you might be more convinced to get a colonoscopy at that point.
Yes, no, I think that's great advice. And I also think it's good advice to say, talk to your doctor about your personal risk levels. And if your doctor is able to talk to you about false negatives, false positives, et cetera, about these stool-based tests, as well as, the procedures. Now that we heard from Dr. Parikh, you don't need to be completely generally anesthetized. You could have local sedation. And as she said, there are people that say, just do it. These are all discussions to have with your doctor, because as we were talking about with Manju and her community in Paltown University and CRC Trials Chat, the most important thing is that you're an empowered and educated patient. We have so much power as individuals, but we only exercise that power when we understand the things that we're talking about. And listen, this matters. This matters so much. As Manju said, the risk of getting colon cancer is related to, whether or not you have a colon. So don't think, oh, I don't have cancer in my family. Think, do I have a colon? Yes, I should be screened. And think about people like Mike Sapienza, who had to go through something extremely traumatic in losing his mom, when something as simple as getting a colonoscopy could have changed the trajectory of their lives. So the point of this chat was really to say to all of you listening, take the power into your own hands, understand your risk, understand things like prevention. Manju talked about it, and again, we could talk so much. Healthy diet, healthy movement, healthy mindset, all of those things that impact our individual health patterns. These are the elements of our lifestyles that we've got to pay close attention to, because colon cancer, breast cancer, lung cancer, heart disease, diabetes, all of these things are directly related to lifestyle, environment, as much as they're related to genetics. So really take your power, understand your options, and scared or not, and I'm speaking directly to my husband and Manju's husband, get the colonoscopy. We know that it works. We know that it helps prevent cancer. We know that it helps with early detection. And we need guys like you in our life. We need all of you right now who are saying, maybe I could put that off, to go and get your screening and to tell others how important screening is. So I want to thank both Manju and Aparna for their time today. Also Mike, and all of the time that they've taken to do things like this. Ask us whatever you need at Total Health Conferencing. We are a great resource for pointing you in directions of credible information. And I want to thank you all for your time and listening to this health